I know it is shameful for someone who was born in Iran to not have mastery of the Persian language. So I apologize in advance. And what I want to share with you is about what I and my colleagues have learned about leadership. There are many very humanitarian physicians in this audience who are, many of them are public health activists who have done amazing things in their career. And I have learned a lot from these individuals, and they know who they are. So please forgive me for not mentioning each one by name, but what I'm going to share with you is partially because of their mentorship. So the topic, the theme of this conference, which is Pillars of a New Society. Of course, one of these pillars is leadership. Despite the trillions of dollars that are spent on social injustice and addressing the problems of health and poverty the world over, these problems have not gotten any better. In fact, they've gotten much worse. And the world has really failed to address the major global issues of our time, like global warming, the failure of the global economy, violence, inequality, among many others. According to the World Economic Forum's 2015 survey on the global health agenda, a startling 86% of those who responded perceived a crisis in global leadership. The most distrusted among the world's leaders were religious leaders. Next, government leaders. Next, business leaders. And then non-governmental leaders. But even charitable organizations were suspect, with only half of the respondents showing any confidence in them. Among the key ingredients identified for success of leadership were morality, prioritization of social justice, empathy, collaboration, courage, a global perspective, long-term planning, and good communication skills. And we can see evidence everywhere we go, in every country, including our own, that these skills are lacking. When the World Health Organization evaluated its initiative called Health for All by the year 2000, this was a global initiative in which the representatives from all over the country gathered in Alma-Ata. And they decided that it was possible for the entire population of the world to have access to primary care. They said it was easy to do, they would do it by the year 2000. So it was called Health for All by the year 2000. And 10 years into the program, there was an evaluation by the World Health Organization. And they determined that this global initiative had failed, not because of lack of resources or lack of finances or the personnel, but because, and the World Health Organization used this term, because of lack of moral leadership at every level. So this issue of leadership is a very critical one. When I started my career as a young ophthalmologist, I was very idealistic. I had learned that, there were, at that time they said there are 45 blind people in the world, and another 200 million, 45 million blind people, another 200 million with low vision, and that 80% of blindness was avoidable. That means it was either curable or preventable. And half of the blindness was from cataract, which a simple operation can cure. So to me, at the time, the problem seemed very simple. Just find the blind people and cure them. And I thought, well, if you mobilize the resources, you get enough doctors to go to these areas and cure the blind, we can take care of this problem. However, what I and my colleagues, those I've worked for, we learned that it is really very complicated. In fact, Baha'u'llah tells us that without the recognition of the oneness of humanity, these problems are insoluble. And so I want to take you on a personal journey of learning during my career of over 30 years in 10 countries and 13 different projects. So I started out in the island nation of Grenada. It's a tiny island, beautiful island in the Caribbean. It's about 20 miles by 10 miles and a population of 100,000 people. In the mid-1980s, the United States invaded this tiny island, and which was supported. Many of the services were supported by the Cubans. When the Cubans left, the entire infrastructure collapsed. And so this project was to build up eye services from the ground up. And during this period, we were there for almost 3 years. We were able, through this project, to establish modern eye services that are sustained to this day. So to me, it was an intoxicating experience because I saw that it's possible to really build a national eye care system from the ground up and make it sustainable. But I really didn't have a clue at that time what it really takes to do such a thing. So about 3 years later, I joined an ophthalmology practice in Chicago. We went back to the US, but my heart was really taken with this kind of work. And so for the next 2 years, we made short visits to different places where eye care was needed, through an organization called the International Foundation. Among these countries, Turks and Caicos Islands, also in the Caribbean, was particularly interesting because there was no local services available. What they would do is they would round up the patients who needed eye surgery or any kind of complicated eye care, and they would recruit ophthalmologists every 6 months to go to this island and deliver care. And so I was one of those ophthalmologists that volunteered to go, and I learned something really, I think it completely changed the way I thought about this. Because, I went through this organization, they donated supplies, they provided surgeons, but the local doctors and patients received this assistance, but they resented it. They didn't really want to have this kind of dependency. And in fact, of all the places I've ever traveled in the world, I've never seen so much distrust of foreigners. So it really forced me to re-examine my assumptions. And the first important lesson we learned is that charity is not a long-term solution. It has a role in times of crisis. Sorry. I haven't been advancing the slides very well, sorry. So while it has a role in times of crisis, to use it long-term is harmful. It strips people of their dignity. Shortly after that, Health for Humanity, which is a Baha'i-inspired organization, was born in 1992. We applied for grants and undertook efforts to address a variety of health concerns, including addressing the leading causes of blindness. We knew we had to focus on building capacity rather than just charity, but we didn't really know what does that mean. What does it mean to build capacity? So we did what most organizations in this arena did, which was a combination of charity and technical training. At that time, this term capacity building was a buzzword among organizations involved in development. And it sounded really wonderful, But it was essentially technical transfer of knowledge. That's what capacity building meant. One of our projects was a 10-year project to develop eye services in Albania. This was a country that had emerged in the early 1990s from 50 years of complete isolation, and services and institutions predated World War II. We got busy training doctors by sending volunteers to Albania to train the ophthalmologists in country. We also sent ophthalmologists abroad for specialized training. We supplied 6 eye centers so that the entire country would have access to eye care services, and helped to develop a residency training program for young doctors at the University Eye Hospital in Tirana. Throughout the project, however, we noticed problems. You know, we had all this funding to provide equipment, but sometimes the equipment didn't arrive where it was supposed to. It would get diverted somewhere else. Sometimes, you know, instruments would disappear. Medications would go where they were not supposed to go, or would disappear altogether. And decision-making was very nepotistic and self-serving. So we knew that a spiritual dimension was needed to see real transformation, but we didn't know how to incorporate that. However, we learned our next important lesson, which was capacity building is not only technical transfer of knowledge. It's not just training doctors to be surgeons. That's not capacity building. So halfway through the project, just when we were initiating a project to control river blindness in Africa, we came across the work of Dr. Eloy Anello and the training he developed in moral leadership at the university that he founded in Bolivia called University Nur. With his help, so we thought this might help us with the challenges we were having, and with his help, we began to introduce this training both into the Albania Eye Project and into the project in Cameroon. The response of the participants was very enthusiastic. In some cases, it was even moving to see how they responded to the material. And so we were convinced this was a helpful addition. Excuse me, my mouth is getting dry. However, we didn't really have an effective way to measure the impact or to even incorporate it in a systematic way. So our work in this area was quite haphazard, I tell you, although several projects were recipients of this training. And we didn't get deep insight into its transformative power until we did an evaluation of the Albania Eye Project 10 years later. We went back, and some of the people who went on with me on that evaluation trip are in this audience, so I thank them for their support. We went back and reviewed the work at the 6 eye centers, which are on the slide. You can see them spaced throughout the country. The first thing we noticed is that the doctors we had trained had become quite prosperous. Some of them even had villas on the sea. Eye services were available throughout the country, and the ophthalmologists seemed to be well trained. The Albanians could receive quality eye care almost everywhere. It was accessible to them, and the cataract surgery rate had increased 20 times. Some patients even were coming for care from Kosovo and Macedonia. All of that was good. However, we learned something that was very disturbing. Those who were receiving this care were the same people who could afford to go to Greece and Italy for care, which is what they did before eye services were available in Albania. So those who could afford the services were served easily. However, people who could not pay, who didn't have the resources, were still not receiving care. So the problem of blindness, which is rampant among the poorer people, was not really getting addressed. This was extremely distressing. And so we had to, as we went around, we asked the different doctors and the nurses if they had anything else to share with us, because we had a questionnaire, and after they finished this, they had an opportunity to volunteer something. So one of the nurses, in fact, the head surgical nurse, had this to say to us. He said, "I'm surprised you didn't ask me about this leadership training. It changed my life. It was the best part. After that, I changed my style of communication with those under me. They saw a difference in me, and they liked it. They changed too. The way we organize our work changed completely. We never used to prepare the patients for surgery. We never said anything to them. We talk to patients now. We explain everything, and we answer their questions. We have a new relationship with each other and with the patients. We have a new vision now, and it is growing as we learn more." And in fact, he took the initiative to incorporate this kind of training into the nursing school curriculum and offer to teach it. We were so excited to learn this that we went back and re-interviewed the attending doctors and those who had been residents during the training. So one of the residents told us, "The training completely changed the way we worked. Before, we didn't even know each other's names, and everyone was competitive and private with information. After, we saw that it is better for us to help each other and share information. We were much happier and learned more." However, what about the attending or the senior doctors? This is what one of them told us. "It was like a good movie. It was great at the time, but when it was over, it was over." So it seemed that people who had power were not so affected by this. It was the residents and the nurses that had the benefit, and nurses more than the residents. So it seemed like the effect was inversely proportional to the amount of agency people had. But we suspected that if this kind of training was intimately woven into all the training we were doing, that it might help to create a spiritual framework that the doctors could use when they were making difficult decisions or when they were planning their future. Clearly, without such a framework, decision-making was going to be self-serving, and the technical and skills and knowledge that they were gaining would not necessarily benefit the community. It could even do harm. And this supplied us with our next lesson, which was true capacity building isn't just technical transfer of knowledge. It has an indispensable spiritual dimension. Throughout this period, we were collaborating with the World Health Organization and the International Agency for the Prevention of Blindness. This is a multilateral organization that works with the World Health Organization for the elimination of blindness by the year 2020. And this initiative is called Vision 2020, the Right to Sight. So the ophthalmologists in the audience will recognize this initiative. We were curious to learn. We were having so much difficulty in our projects with these issues of ethical principles, violation of ethical principles. In really every project we had, we came across these problems. So we were curious, what these other organizations, were they having similar issues or not? So we sent out a survey to the members of the International Agency for the Prevention of Blindness. At that time, there were 94 institutional members, 80 of which were non-governmental organizations, and Health for Humanity was one of them. The survey was sent out to 147 individuals. Of these, 61 responded. That's a return rate of 41%. So these are the survey results. 93% felt that moral values were essential to their success. 83% said effective leadership is a significant challenge for them. 66% stated technical training had failed to give them the results they hoped for. 54% were having problems with honesty and trustworthiness. Many of them had difficulty, volunteered that equipment and supplies were stolen. 32% said their projects were struggling, and many of them said, look, our projects are not effective at all. Almost all stated that some equipment or funds were diverted to unintended uses. When asked to rate the ingredients for success, 74%, surprising 74%, rated moral values and ethical behavior as the most important, and surgical skills and academic knowledge as the least important. This really surprised us. We would have guessed the reverse. When asked to prioritize ingredients for success, the top 3 they identified were strong core values, service orientation, and honesty. So these were the top leaders in their field, in the world, and they were acknowledging that moral values are indispensable to success in addressing public health challenges. So clearly, what we were experiencing was shared among other organizations working in health development and very likely development in general. When we shared the results of this survey with the IAPB member institutions, we were invited to offer the leadership training to these organizations at the next General Assembly meeting, which was 2008 in Argentina. The anecdotal stories that we heard, together with the survey results and the unexpected interest from member organizations and multilateral agencies, convinced us that there is a great need for this. So our 4th lesson, there is growing consensus among leaders in health development, and I would say development in general, that without the moral and ethical dimension, development efforts will not succeed. Meanwhile, just as the Albania project ended, we received funding to carry out a more modest project to train cataract surgeons in Ulaanbaatar, Mongolia. With each new challenge, we were increasingly convinced that this kind of training had to be intimately integrated into the project. We tried to apply the lessons that we had learned from the past decade to the activities we were planning in Mongolia. And we used the training developed by Dr. Anello and translated the manual into Mongolian. In fact, he assisted us with this process of delivering the training through some of his colleagues, and he himself even made a trip to Mongolia. At that time, Mongolia was deeply entrenched in an authoritarian style of leadership. And it was prevalent throughout the healthcare system, I'm sure throughout all other systems, but I only was able to witness the healthcare system, where one person made all the decisions and everyone else deferred. We were able to convince the director of the eye department that the training would be good for the department and it would be good for her. So she finally agreed, but it was not easy for her. After decades, maybe even centuries, of patterns of behavior that required passivity on the part of most people and the very strong dictatorial style on the part of the leader, it was really hard for her to give up that authority, and it was hard for the others to find their voice. So at first, we were wondering if this training would even make a difference because of this hesitancy. But then we said, well, maybe it's a process. We will just do what we need to do and hope that it will work out. And indeed, within 2 years, we started to see change. One of the doctors in Mongolia shared the following comments at the presentation she gave at the International Agency for Prevention of Blindness. She said this training was totally different. We always talked about academic knowledge, clinical and surgical training, but the importance of changing attitudes and behaviors had not been considered. So the training made many people think about who we are, what we are doing, and where we want to be. The most important impact of the training was that people started to express themselves, express their views. Before, it was rare to hear anyone share what they truly felt. There was fear. But after the training, we felt like we got new eyes. Now at the different meetings, those who participated are not afraid to express how they really feel. Now we make decisions through consultation within the group and try to include all the doctors. After the second training, 10 ophthalmologists from different hospitals in Ulaanbaatar decided to meet regularly to solve problems and make decisions. Wow. To us, this was a transformative experience seeing this. They had learned about consultation. And we find that this skill is absolutely the most powerful mechanism for system transformation. So, our fifth lesson. Consultation is the most powerful mean for system transformation. However, our greatest confirmation came from the Secretary for Health, Dr. Batsaredin. She said, "I remember how bad the conditions used to be, and now the eye department is a modern department with high-quality services. However, it is not just the technical improvement that is noticeable. There is something else I have not seen before. The doctors treat the patients differently. The ophthalmologists changed. They have a very good relationship with the patients and with each other, and have now become a model department not only for the hospital, but for all of Mongolia. I want to see this spread." So there was no longer doubt in our mind that if we wanted to have lasting impact, we had to incorporate spiritual principles within the training efforts, and the effects could be far-reaching. So our sixth lesson, the outcome of a spiritual framework is transformation of relationships that is measurable. Because we always thought, how do we measure this? But indeed, we can measure it. We can measure it through qualitative methods. Then as the Mongolia Eye Project was winding down, I was invited by a consulting company, Second Muse, to assist with leadership training for the World Health Organization Good Governance in Medicines program, an initiative to fight corruption in the pharmaceutical sector. Dr. Aloy Anello was already a consultant for WHO, and he was involved in this project. And this is when I had a chance to work with him directly. We had worked together in Mongolia and in these other projects more indirectly, but this was my chance to work with him on a daily basis, even though it was long distance, but through email and conference calls. So we collaborated on rewriting and expanding the training manual he had developed, and worked together to develop training materials for representatives of the ministries of health, first in Amman, Jordan, for the Eastern Mediterranean region, and later in Geneva for representatives from all over the world. And this is how Dr. Anello's book, Transformative Leadership, Developing, here it is, Developing the Hidden Dimension. This is how it was published. He had asked us to collaborate that summer to take the work we had done together to publish a book in English. Unfortunately, his health did not allow that, but collaboration with his other co-author, Juanita Hernandez, permitted us to publish this book 5 years later. And then last year, we also published a workbook, companion workbook, and this book has also now been translated into Chinese. In 2010, we had the privilege to move to China, the country of the future, as Abdu'l Baha said, but also a country with the greatest burden of blindness in the world. While modern eye care is available in the big cities, it is virtually non-existent in the rural areas. And that's where most blind people are. They're in the low and middle income areas of the world where resources are lacking. So we formed another non-governmental organization in China called Vision in Practice, or ICAI in Chinese. We were fortunate to obtain the assistance of a hospital that has set the global standard for high-quality, affordable care in the world, called Aravind Eye Hospital. They see more patients, do more surgeries, train more ophthalmologists, and do more specialized training than any other hospital on the planet. And it's an amazing place. I spent a month there, and I was witness to the miracle that they perform. A third of their patients are seen without charge, completely free. 1/3 are subsidized, and 1/3 pay market rates. And every year they do 500,000 operations. And they train thousands of ophthalmologists for the rest of the world. And they manage to make 35% profit annually. It's an amazing place. Anyway, they agreed to work with us, with these hospitals in China. So with Arvind's help, we were able to send some 80 Chinese ophthalmologists for surgical training. We assisted 6 hospitals to be directly mentored by Aravind, and worked intensively with 2 of them to transform eye services. This is one of them, Xinyimin Eye Hospital in Shandong Province. And a good example of the impact of the training on a personal level was from one of my colleagues who worked with me in the eye projects, Chinese colleague. And after our work together, she took a job with a financial institution. She told us that her job was very stressful, and she was expected to do all kinds of things that she was not comfortable with, while those around her were sort of enjoying these perks by bending the rules. She was just on the sidelines. However, within a year, the entire team that she was working with was fired. She and one other person survived, and this is what she told. She said being honest was easy at first. When she wasn't challenged, it wasn't really an issue. But when everyone else was compromising and putting pressure on me, it was stressful. But I remembered our training and the importance of values. I knew what I had to do. So she remained strong. And an example on an institutional level in China is from this hospital called Xiantao Eye Hospital. It's actually Aipo Eye Hospital in Xiantao, Hubei Province, China. This was a hospital in which there were 6 ophthalmologists. It was a small rural hospital. Actually, Xiantao, they told me this is a village. Population, 1.5 million. Villages in China are like our big cities. Anyway, so at this hospital, of the 6 ophthalmologists, there was only 1 surgeon. And the care that they were giving was not evidence-based and was extremely haphazard. Patients were not getting good care at all. And so in partnership with Aravind Hospital, we initiated this 2-pronged approach of both academic and technical training, along with moral leadership training. And within 2 years, the training center, a cataract surgery training center was established so that all of the ophthalmologists could be trained as surgeons. And all patients received comprehensive eye care, including surgery if they needed it, whether or not they could pay. And the surgical volume of this hospital doubled, and they also increased their profits. And now, while there's still great room for improvement, they have guidelines that they have agreed to themselves to help them make decisions. Many of their self-serving policies have now changed. And this is what the chief surgeon told us. She said, "We see things so differently now. When we live by the moral values, we feel more confident. As a result of the training, we feel the strength to overcome any kind of problem. We learned how to work as real doctors, how to create a team that is service-oriented or service-aimed, how to encourage each other to keep learning and believe in ourselves. When we improve, it makes us happy. Even when it is difficult, we can make wiser choices than before. We've been talking about leadership training in these various places, but I haven't really told you what it really involves. So I'll just give you a brief glimpse. We had a workshop yesterday where we went into a little more of the details of the kind of exercises that we do. But just to share with you that our guidance comes from the Baha'i writings. And if you do a search of the Baha'i writings with the word leadership, you will not find very much. Because unless it's about the manifestations of God, then you will find a lot. But leadership that refers to anything but the manifestations of God, the reference is corrupt leadership, or lust for leadership, or hunger for power. There's not much in the writings about leadership. But if we look for examples of leadership in the Baha'i faith, we come up not with leadership, but with servitude. Our most inspiring example, of course, is Abdul Baha, who explained his station. He said, "My name is Abdul Baha. My identity is Abdul Baha. My qualification is Abdul Baha. My reality is Abdul Baha. My praise is Abdul Baha. Thraldom to the blessed perfection is my glorious and refulgent diadem, and servitude to all the human race is my perpetual religion. No name, no title, no mention, no commendation hath he nor will ever have except Abdul Baha. This is my longing. This is my supreme apex. This is my greatest yearning. This is my eternal life. This is my everlasting glory." In fact, Abdul Baha equates leadership with servitude. And he says, "This is not servitude, but sovereignty. And this is not service, but chieftainship and greatness. This is the garment of everlasting glory with which thou hast clothed thyself. And this is the rose of eternal exaltation with which thou hast adorned thy head. It is said in the New Testament, whosoever will be chief among you, let him be your servant." So while the title of that book I shared with you is Transformative Leadership, and I tell you, Dr. Eloy Anello, he never liked that term, leadership. But he said, what should we call it? People expect to hear about leadership. What should we call it? But really, the true title should be Transformative Servitude, which is a process of personal transformation and service to the community, our twin moral duties. So just very briefly in the training, what we try to do is to help the participants examine their own assumptions that are standing in the way of their work. Their assumptions about what is a leader, what is success, what is happiness, what does it mean to be a doctor. And once they examine these assumptions and find them to be faulty, then we help them to sort of resurrect elements of their own spiritual heritage from which they can create a spiritual framework for their work. And this framework then is based on universal human values, moral and ethical principles, and they agree among themselves, this is how we're going to work. If we have a problem, these things we will not violate. There's zero tolerance for certain things. And then when they come across a crisis, they're challenged to make decisions based on those things they all agreed on. And so finally, our final lesson is true leadership is servitude, and servitude is a spiritual journey of personal and collective transformation. For it is through service that we transform both ourselves and our environments. Thank you.